Dr. Tammy Fouse, and I'm the medical director for the Empower Weight Loss Program at Bingham Memorial Hospital. I'm really excited to have you here today to take you through our online seminar explaining how you can go through our program and have success with your journey with weight loss. So we're going to get started. And before I begin, I would like to just let you know about a little bit of background about our program. We are an accredited center of excellence. What that means for you is that we have an accrediting body that governs all bariatric surgery in the United States that actually comes into our facility every 3 years and reviews our entire program for safety, for patient outcomes, to make sure that we have the appropriate facilities for our patients. And we're very proud to say that we've been reaccredited 3 times now. Our most recent reaccreditation was in 2018. So we're very proud of that status. We are one of 2 accredited bariatric centers in the state of Idaho, the other one being Boise. Our goals today for our seminar are to discuss a little bit about what is obesity as a disease. We're going to talk about what we know, what causes obesity in the year 2020. There's significant amount of research that goes on every single day in the obesity field, and I'd like to share with you what we know today to be some of the major causes of obesity. We're also going to talk about the health risks of remaining in an obese state. We'll talk about implications to our overall health as well as how it increases our risk of cancer. And then we'll talk a little bit about how we treat obesity and what our best methods are, again, in this day and age in 2020, what we know today to be the most effective ways to treat this disease. And then lastly, we'll talk about what the treatment pathways that are available to you through the Empower program at Bingham Memorial Hospital. So we're going to start our seminar by talking a little bit about what is obesity. And in the most simple definition, obesity is simply just excess fat in the body. But I would take that a little bit further and say that it's actually excess fat in the body that leads to end organ disease, such as hypertension or type 2 diabetes, for instance. And in 2013, the American Medical Association actually went so far as to designate obesity as a chronic disease. So that's very similar to you sitting in your physician's office talking about high blood pressure, as I said, or type 2 diabetes, or maybe COPD. Those are all chronic diseases that don't necessarily get eliminated per se, but they are treated and the result of those diseases are controlled. Obesity is now classified as the same type of disease as any of those others I just mentioned. And what that means to us is that we now have better options as it relates to insurance coverage to treat this type of disease. We measure disease severity in 3 different ways. We look at body mass index, we look at body fat distribution, and then lastly, we look at body fat percentage. So let's spend a little bit of time talking about these severity measurements, as I mentioned. We'll start with body mass index, and it's really just a measure of body weight that's useful for classifying health-related risks that go along with different BMI categories. It's based on the concept that your body weight and your height should be in proportion to each other. And body mass index is broken down into different segments. Normal BMI is considered to be between 18.5 and 24.9. We become overweight when our BMI is 25. And then when we hit a BMI of 30, we're considered to be obese. And then morbid obesity starts at a BMI over 40. Now, there are some limitations to BMI, so it is not the most perfect measurement of disease severity. However, it is a very important one that we'll talk about in just a moment. But the limitations are that it's just a measurement. So when you step on a scale and you take your weight, it's going to give you one number. You calculate your height, you know that number, then you calculate your BMI from those 2 numbers. But it doesn't take into consideration what that weight is made up of. Is it excess fat? Is it muscle? Is it tendon, bone? All of the different organs or components of our body aren't really broken down into their segments. So to illustrate that, I'll show you a cartoon here that both of these gentlemen have the same weight of 250 pounds. They're both 6 feet tall, which means that their BMI is 33.9. But you can see by the illustration that their bodies are made up of vastly different components. The gentleman on my left, his body fat percentage is around 6%, and this gentleman on the right side of our cartoon, his body fat percentage is probably around 67%. So you can see that even though they have the same BMI, there's a lot of difference in what makes up that BMI number. But if you use the chart that's in your informational packet, you should be able to calculate your BMI and understand where you fall on that range. Why do we use the BMI then if there are some limitations? And we use it because the National Institutes of Health they use the BMI to determine who's a candidate for bariatric surgery. If your insurance covers bariatric surgery or even non-surgical weight loss options, we use BMI to decide who's a candidate. And if your BMI is 40 or more and your insurance covers bariatric surgery, you're automatically a candidate for surgery. However, if your BMI falls between 35 and 39, you will be required to have a weight-related illness in order for your insurance to cover bariatric surgery or other non-surgical options. Those weight-related illnesses can be high blood pressure, type 2 diabetes, or obstructive sleep apnea. Any one of those three would qualify you for surgical coverage. Insurance providers follow these guidelines very closely. So Medicare and Medicaid set the standard as to who's covered for these surgeries, and then our private insurance companies follow Medicare and Medicaid's guidelines. So it's very important that you understand what your BMI is as it relates to coverage from your insurance company. The second way we measure disease severity is we look at body fat distribution, and we as humans distribute our excess weight in one of two ways. We either distribute the majority of it above our waist, what we call apple-type fat distributors, or we distribute the majority of our excess weight below the waist, what we call a pear-type fat distributor. So the common question is, why does that matter? Well, there are actually health implications that go along with how we as humans distribute our excess weight. If you're an apple-type fat distributor, you're going to have more of your excess weight inside the abdominal cavity around the waist. And this excess fat is actually different. It's a fat that bathes your internal organs, your pancreas, your spleen, your liver, your kidneys, your colon, and all of our other vital internal organs inside our abdomen. This fat surrounds all of those organs inside, and it's actually metabolically active. It secretes hormones that promote disease, cardiac disease, type 2 diabetes, etc. In an apple-type fat distributor, which 95% of these are men, they actually have very little fat underneath their skin, so it's very hard to pull up a thick fold of skin on an apple-type fat distributor. If you compare that to a pear-type fat distributor, most of their excess weight is below the waist. 99% of these patients are going to be women because we have the extra weight below our waist in order to bear children and sustain a pregnancy. But when you look inside their abdomen, they have very little fat, excess fat inside the abdomen, again, around those vital organs. But they have a very thick fold of fat right under the skin. So it's very easy to pick up a thick fold of fat in a pear-type fat distributor. The reason that we care about this is because these two types of fat are different, as I mentioned earlier. One is very metabolically active, promoting disease and promoting inflammation. The other one, while still not good for you overall, isn't quite as detrimental to your health as being an apple-type fat distributor. So next I'd like to talk to you about what we know about the causes of obesity are in the year 2020. We know this is a very actively researched area of medicine all over the world, actually, not just in the United States, but we've learned quite a bit about what causes it. But what I'd like to ask you is how many of you, if you think about it, have sat in your doctor's office or perhaps sat around the table after Sunday dinner with your family and talked a little bit about the need or the desire to lose a little extra weight, or maybe your doctor's told you that you need to lose a little bit of weight. And, you know, when you express that desire, they ask you, well, why can't you just eat less and exercise more? Why don't you have more willpower? And we are absolutely inundated in the United States and around the world with different weight loss options, diets, food plans, food pyramids, different types of shakes and medications. And we're inundated with pictures in the media of the way that we're supposed to look, only to lose and gain and lose and gain the same amount of weight over and over, only to be left more hopeless and frustrated each time we go through this endless cycle. We know, again, based on a lot of research that's taking place every day across the United States and globally for that matter, we know there are multiple factors that go into contributing to obesity. And the first thing is genetic influences. When we first started looking at these genetic influences, there were 29 different genes that were associated with how the human body stores extra weight. Now there's well over 100 genes that go into contributing to how I, for instance, would store excess calories in the form of, say, a carbohydrate-loaded meal like spaghetti versus somebody that sits next to me and eats the same plate that doesn't gain any weight after eating that type of food. So we know our genes have a very important part to play in how we store extra calories. We also know there's important hormones that become dysregulated. When you become obese, we have two major hormones that control our appetite. One is what we call the gas pedal, which is called ghrelin, and it's secreted in our stomach. So if you think about that time period between your meals when you're hungry and you get the growlies going on in your stomach, that's really our hormone ghrelin that's secreting, telling us it's time to eat. So that's putting the gas pedal on our appetite, saying it's time to eat, and you're hungry. We have an opposing hormone that tells us that we're full and tells us to stop eating. And that opposing hormone is called leptin. Now, leptin is actually secreted in our fat cells. So it's secreted from the fat cells and essentially sends a signal to our brain telling us that we're full and it's time to stop eating, which is great. You think, if you're in an obese state and I have excess fat in my body, I should be getting that signal telling me to stop eating. However, when we get to a certain point of obesity, that leptin signal that goes to our brain is actually not received. We have something that happens called leptin resistance. So we get the gas pedal in the form of ghrelin, but we don't get the brake pedal in the form of leptin because of leptin insensitivity. We also know that stress is a big contributor to creating and maintaining obesity. Our lives are more fast and more demanding than ever. We have multiple jobs in some cases. We have financial concerns. We're taking care of children, maybe going to school, taking care of aging parents. There's a lot of demands on our life in this day and age. So there's actually a hormone that's secreted when we're under chronic levels of stress called cortisol. And that increased level of cortisol can also start a cascade of events that go on in our body that contribute to obesity and keep us in that obese state. So it's very important, as part of the treatment strategy for obesity, is to deal with the stress levels and the behavioral adaptations that we have that contribute to these stress levels remaining high. What you may not be aware of is that sleep can actually also contribute to obesity. If you remember a few years ago when Princess Leia from the famous Star Wars series died, she actually died from complications related to sleep apnea. So let me explain. There's a lot of research also going on. We're hearing a lot more and more about how sleep contributes to obesity. Let me try to explain how that works in our world. When you have extra tissue around your neck, or you may have extra tissue around your waist, and you lie down at night to go to sleep, this extra tissue around your neck can actually collapse your airway, making it very difficult to move that air as you sleep. The extra tissue around your waist pushes up on your diaphragm and your lungs, making it very difficult to move air in and out of your lungs at night when you lie down to sleep. So when you lie down, your oxygen level starts at a normal rate. As you lay down and go to sleep, this extra tissue is collapsing your airway, this extra tissue is pushing up on your lungs, and your oxygen level can drop down to a certain level that your brain recognizes that, we're in trouble here, we need to take a breath. So what your body wakes you up just at enough of a level to take that big gasp of air and to take a breath and get your oxygen level back up, and that cycle then continues throughout the night. Oxygen level's normal, it drops down, you're wakened up enough subconsciously just to take that breath, get your oxygen level back up, and that cycle goes on and on throughout the night. The problem being, because you're constantly being awakened to take those extra breaths, you never really reach a deep restorative level of sleep, what we call REM, or rapid eye movement level of sleep. That REM level of sleep is where we actually get restored. So when you wake up, your alarm goes off in the morning, and your eyes pop open and you feel rested. If you don't feel rested, like you've never really slept overnight, chances are you probably haven't really slept well overnight because of these constant waking cycles that are going on. And what happens during the day when you wake up and you haven't really had a good restorative level of sleep, come the afternoon when you're going through a busy day, you feel tired, you feel run down, you're subconsciously driven to crave certain substances like sugar, carbohydrates, caffeine, to give you those bursts of energy to get you through the rest of the day, which means that you don't really necessarily know why you can't withstand those cravings. A lot of times it's because of poor quality sleep. So I'd also like to share with you a study that was done a few years ago after a season of The Biggest Loser television program. They actually went and measured the rate at which the contestants for this television competition, They measured the rate at which their bodies burned calories before the competition started, and then they followed them through the competition as they lost their weight. They measured the rate at which they burned calories after they lost their weight, and they saw a stark difference in the number of calories that were burned before the weight loss and after the weight loss. So let me share a quick 2-minute video with you about what their findings were.
We are inundated with weight loss before and after pictures and reality TV shows where overweight contestants end their seasons quite literally half the man or woman they used to be. But now a new study says if you're one of the many who regains weight after losing it, your body may be to blame. In a recent study, a group of scientists followed 14 of the 16 contestants from one season of The Biggest Loser, monitoring them for the 6 years after the show. They found that all but one of them gained the weight back. According to the study, while the contestants all had normal metabolisms for their size at the start of filming, years after it was over, their metabolisms continued to slow down, a mechanism the body uses to return to its original weight. Further compounding the problem, researchers found the contestants had plummeting levels of leptin, a hormone thought to help control hunger, which left them constantly feeling hungry.
After you lose weight, your body's metabolic rate will slow down. The number of calories that your body requires is going to decrease, and that's going to make it difficult for you to keep the weight off.
I've gotten my life back. I mean, I feel like $1,000,000.
Difficult for people like Season 8's winner Danny Cahill, 430 pounds before the show, 191 pounds after, but gained nearly 100 pounds back after he returned to work. And Dina Mercado, 248 pounds before the show, down to 173.5 pounds, now back to almost 206 pounds. The study found her metabolic rate now burns almost 438 fewer calories per day than would be expected for a woman her size.
Had I known what I know today, I probably would have not done the show. I didn't want anybody to know I was on The Biggest Loser because obviously I don't look like that anymore.
But J.D. Roth, co-creator and producer of The Biggest Loser, defends his show.
When the people leave our show, they are better off than being 400 pounds. I do think the study could have done things a little bit differently. I would have also liked them to take 14 people who kept the weight off. We need to use both to come up with the best way to be healthy because we all know we're still trying to figure it out.
So when you think about the genetic influences, the hormone dysregulation, stress levels, sleep disruption, the actual changes in our metabolic rate or the rate at which we burn calories with obesity, I go back and ask you the original question, is it really all about willpower? I have to say emphatically no. There's so much more to treating obesity and what causes obesity than simply having willpower. So let's talk a little bit about the health risks of remaining in an obese state. And those health risks start at the top of our head in the form of migraine headaches and go all the way to the tips of our toes in the form of gout, with many, many other comorbidities along the way. Fatty liver disease, acid reflux, type 2 diabetes, hypertension, coronary artery disease, degenerative joint disease, etc., just to name a few. But what you may not be aware of are the health risks that go along with obesity in terms of cancer risk. We know that this list of cancers are at a much increased rate of occurrence based on obesity. The two that affect the most of our population in the United States would be colorectal cancer and postmenopausal breast cancer. You're anywhere from 1.5 to 3 times at a higher relative risk of developing these cancers if you remain in an obese state. So obesity treatment in the United States really centers around 2 avenues: surgical weight loss or non-surgical weight loss. So let's spend a little bit of time talking about each of these individually. Surgical weight loss in the United States is what we call bariatric or metabolic surgery. And you can see from this chart that in 2016, we did just over 200,000 bariatric procedures in the United States. The most recent data would show that number to be fairly consistent at around 220,000. But the makeup of these surgeries have changed pretty considerably over the last, say, 7 or 8 years. The Roux-en-Y gastric bypass used to be over about 1/3 of all bariatric procedures in the United States. It's now dropped down to probably around 17%. The lap band used to also be about 35% of all bariatric procedures. It's now done probably around 1% of the time. And the reason is because the sleeve gastrectomy has been developed and come on to be a very important player in this surgical offering to our patients, and now is well over probably 70% of all bariatric procedures done in the United States are the sleeve gastrectomy. So at Bingham, we offer the sleeve gastrectomy. Again, it is the most commonly performed procedure in the United States. I would caution you, however, if you have uncontrolled heartburn, we will need to do a little bit more testing to make sure this is the appropriate procedure for you. We also offer the gastric bypass. This has also been demonstrated to have a very dramatic impact on diabetes treatment, as well as if you do have uncontrolled heartburn, this may be the more appropriate choice for you. One of the newer offerings that we have at Bingham is the intragastric balloon, and we'll talk a little bit more about that in a moment, but it was FDA approved for BMIs between 30 and 39.9 back in 2015, so it's only been around about 4 or 5 years. I would also caution you on this with uncontrolled heartburn, and it is not currently covered by insurance. It is a cash pay option, but it might be appropriate for you if you have, say, 30, 40 pounds that you want to lose and you're not interested in surgery. We also offer lap band adjustments, we offer lap band removals, and we offer lap band conversion to another procedure if your lap band has not been successful or you're having troubles with it. We could certainly talk to you about the options that exist to convert your band to another procedure. So let's talk a little bit more in detail about the sleeve gastrectomy.
Small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. Surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes to help break down the food into a more simple form so that it can be more easily digested and absorbed once in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy.
So as you can see from the video, we do a stapled line, and this is very similar to the stapler that I use. It's not exactly the same, but it does lay down a triple row of staples on the stomach that stays in the body. This part of the stomach comes out. The important part about this is that the top part of the stomach that's removed is where that hunger hormone ghrelin is secreted. So it's very common for a sleeve gastrectomy patient to not have hunger for at least 9 to 12 months after surgery. You may get some of that hunger back because ghrelin is also produced in the small intestine, but to a large point it is secreted in the top part of the stomach called the fundus, which is removed during a sleeve gastrectomy. Now, this metal that we use for the staplers is a titanium metal. It's perfectly safe to stay in the body. It doesn't set off metal detectors, or you don't have to worry about it if you do an MRI or anything. It's the same metal that would be used if you had maybe a metal implant for a joint. So it is a hypoallergenic metal. You can expect a one-night stay in the hospital with the sleeve, and usually folks are able to return to most jobs within a week or two after procedure, depending on the type of work that you do. So next, we're going to talk a little bit more in detail about the Roux-en-Y gastric bypass.
Small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. This smaller stomach pouch restricts the amount of food that can be eaten before feeling full. The small intestine is separated into 2 sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. Bypassing a portion of the small intestine decreases the absorption of calories and nutrients. The upper portion of the small intestine is reconnected to the lower portion of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested.
As you can see from the video, this is a little bit more extensive procedure. Whereas the sleeve takes maybe 45 minutes to an hour to perform, this probably takes about 2 to 2.5 hours to perform because we do reroute intestine. It's usually a 1 to 2 night stay in the hospital. And because we reroute intestine, you do have something we call malabsorption. So as the food stream comes down here and enters into this part of the small intestine, you're not really absorbing calories or nutrients until you meet up here with the digestive enzymes coming down, depicted by the green arrows. So once your food meets these digestive enzymes, that's the point where you start to absorb calories and nutrients. So a caution on those with a gastric bypass, you have to be willing to take vitamins for the rest of your life because of the fact that we do malabsorb some of our food and nutrients. It's not as critical with the sleeve, but it's highly recommended that you do take a daily multivitamin and some calcium and vitamin D, but it's very much required with a gastric bypass. Again, you can expect 1 to 2 night stay in the hospital and return to work probably in a week or 2, depending on the type of work that you do. Now, the intragastric balloon is, again, the newest member of our arsenal to treat obesity. Not currently covered by insurance, and it is done as an outpatient procedure. You come into the endoscopy suite, the balloon is placed, it stays in place for 6 months. During that time period, we restrict the amount of food that you can eat and drink because the balloon is occupying space inside the stomach. And then during that time, you're meeting with the dietitian and the rest of our weight loss team to reach your weight loss goals. The balloon is then taken out, again, as an outpatient procedure. And then you continue to meet with the dietitian and other members from our weight loss team for 6 additional months after the balloon's removed to make sure that you maintain the weight loss. So we also offer non-surgical options at Bingham, and that is basically a supervised weight loss program, again, designed for people that are either not interested in surgery or that have fewer than approximately 50 pounds that they would like to lose. You do a medical review, you come in and meet with me, we do a complete history and physical, we review labs, we review your medications. Then we meet with one of the dietitian members of our team to go over your dietary habits and make recommendations for changes. And you would also undergo a psychological evaluation to look at those stress and behavioral components that are contributing to the obesity. So the treatment pathways offered at Bingham, you've done the first step. You've watched this informative online seminar. The next step would then be to complete the package of information that we will mail to you once we have verification that you've completed your online seminar. We ask that you complete the medical and mental health history packet and also your insurance verification form and return those to our office in a self-addressed stamped envelope. Once we receive your information, one of the members of our team will call you to discuss your insurance coverage and to make a new patient appointment with me. Once you and I sit down to talk, we're going to talk about your goals. What are you trying to achieve in your weight loss journey? I've had many people share their goals with me. Some people just want to be able to get down on the floor and play with their grandkids. Some people want to ride their horse again that they've never been able to ride for the last many years. Some people just want to be able to fit on a ride at Lagoon or sit on an airplane seat comfortably. So whatever your goals are, they're your goals and they're personal. And you and I will sit down and talk about that. And then we'll devise a pathway for you that makes sense, that you're comfortable with, that we can help you get to your goals. Anyone going to surgery will have a dietary evaluation. They'll all have a psychological evaluation. We'll get basic lab work as well as we'll check the heart through an EKG. If you do have significant heartburn, I will do an endoscopy called an EGD, and we'll go into the stomach and actually look inside the stomach and make sure everything's okay for surgery. Everyone will attend a lifestyle class that teaches you about the changes that you're going to need to make in order to be successful. And then based on your medical history, you may need a sleep study or you may need a cardiac evaluation. But I just wanted to make a couple of quick points to you. You must complete that health history before your first appointment with me. That way you and I can have a very meaningful conversation about your health history and your goals. Insurance requirements will affect the time to get to surgery. Some insurances require what we call monitored weight loss, meaning that you have to meet with a dietitian or a medical provider to discuss weight loss efforts and goals for a period of months prior to surgery. The most onerous amount of months that anyone has to do is 6 months, and that's usually with Medicaid. But some people have no monitored weight loss. We won't know until we review your particular insurance coverage, and we will share with you what those requirements are. If you don't have monitored weight loss requirements, it's likely that you could get to surgery in 6 to 8 weeks, depending on your availability to attend those appointments. If you have recently had an EKG on your heart, maybe you've had a recent procedure done and someone already has that for you in the last year, or maybe you've had an endoscopy by a gastroenterologist, I'm happy to go out and get those records and not have to repeat any of those steps that you've already gone through recently. We're happy to go get those results for you. We do have a few program requirements. The first one would be nicotine, and I'm not here really today to discuss the harsh realities about the dangers of nicotine. I'm not here to really discuss that, but what I am here to talk about and I take very seriously is my role to get you through surgery very safely. Nicotine in whatever form, if it's patches, if it's cigarettes, if it's vaping, it doesn't matter what format it comes in, nicotine in the body does the same thing. So if you think about a garden hose in your backyard and water flowing through that garden hose and you step in the middle of that hose and you occlude the flow of that water, that's really what nicotine does to your blood vessels throughout your entire body. So any form that nicotine gets into your body, it restricts or it closes down the blood vessels in your body. What that staple line from your recent surgery needs more than anything to heal is a good blood flow. So we can't have any nicotine in the system during the time of surgery, and insurance is actually going to require a negative nicotine test in order to even approve someone for surgery. So it's a very important thing to understand the requirements, and if you need help in getting off of nicotine, we're happy to do that for you, and we can certainly work with you in the clinic to accomplish that. Sleep apnea. Sleep apnea is a very important very significant health risk when you talk about going to surgery and recovering safely from surgery. If you have serious sleep apnea and it's at a level that it requires a CPAP, we will require that you be compliant with your CPAP mask before surgery. And again, that's just to verify and ensure that you get through surgery safely and the recovery period safely. It's very important to avoid non-steroidal anti-inflammatory medications after surgery. Again, we need that staple line to heal. We need good blood flow to that lining and to that of the stomach and to that staple line. And those types of medications, Advil, ibuprofen, naproxen, meloxicam, that family of medications can be very, very disruptive to that lining of the stomach and the healing process. So very important that we avoid those medications. If your BMI is greater than 60, you will be working with one of our team members to help you get a little bit of that weight off before surgery to get you to surgery safely. Again, I need to make sure that we can accommodate your body mass on the table in the operating room, and for that requirement, we have to have the BMIs below 60. So we may require that you work for a little bit of period of time with some of our team members to help you accomplish that. We also, everyone, doesn't matter what the pre-op BMI, everyone's going to go through a liver shrinking diet. If you think back to those slides that we showed you earlier with the sleeve and the bypass, the liver sits right on top of the stomach where I need to work to get you an effective and a very good procedure. We need that liver lifted up out of the way. And if the liver's too large, it puts a lot of risk into the surgery that we don't need to acquire. So everyone's going to go through at least a 2-week liver shrinking diet right before surgery. And if you gain weight during the preoperative workup phase, we're going to have to sit down and have a talk about that, because it may indicate that maybe this isn't the right time of your life to go through all these changes. So just keep that in mind. If we will have a targeted weight loss goal before surgery, and that just tells us that you're really ready and committed to making these changes so that you can be successful after surgery. I want to thank you for logging on today and taking the time to watch our online seminar. We at Empower know this is a very difficult decision and it's a difficult journey, but we're here to help you every step of the way, and we want to see you succeed and reach your goals. So if you have any questions about what you've seen today during this seminar, please feel free to reach out and give our office a call, and we'll be happy to walk you through the next steps.